Right, welcome to Dr. Carr Society Mission. So this presentation is for obstetrics and gynecology. Okay, we are starting with history taking. Okay, so this is going to be a summary of history taking and how it is done, especially in our part of the world. All right, so now history taking is gathering information from the patient, or it can be a relative. Or somebody else who's standing in for the patient, or a witness, okay, who, for one or two reasons, knows something about the patient's condition, right? So you gathering the information and putting it in context, okay, making it clear so that we are able to say that this is the particular disease we are most likely dealing with. All right, so your history taking should be such that it should follow a pattern for a particular disease. So you can't just start taking your history. You should first of all make sure you go through the whole history, probably even do the examination and all that, so that you have clear picture of what you are dealing with. You have impressions of the conditions you are weighing in terms of the probability of the various conditions that you have in mind. Right? So you should first go through the history, take thorough history, do your examination, make an impression of one or two, three diagnoses, okay? And then let your history follow the conditions that you have, you think are most probable in that circumstance, okay? If you don't do that, you can't just start writing your history straight away from when you start asking the patient questions. So when you ask what brought you here, then you start writing. No, that is not going to work. You should first of all know what you are doing. What you are dealing with, and to know that you should have gone through the history examination and been very thorough with your questioning and then examination, so that you have at least three differential diagnoses before you start writing your history. So you listen, examine before you start writing your history. Other than that, you will not be able to. Your history will not make sense. Okay, because if you don't know the condition you are dealing with, you won't be able to write a proper history. So in essence, this is what people forget to know, that you are not supposed to start writing even if you start asking the patient questions. Okay, you should go through the questioning and then get to your full history, do your examination, come up with impressions. And once you have your impression, your history should follow that impression that you have. Because no condition will have different symptoms being brought up by you yourself, or you can't invent new symptoms for a particular condition that you think the patient has. So once you say it is malaria, the history must follow malaria. Once you think it is cholera, the history must follow so. Once you think it is hypertension, the history must follow so. So you can't think it is hypertension and write history for malaria. No. That is the reason why you should go through the motion, know the condition you are dealing with. And once you get the impression, the history will be the same. The history for hypertension will be the same. The history for malaria will be the same. The history for any condition will be the same. You will not be the first person to bring in new symptoms for a particular condition. Right? And this is what you may not know, or most people are not told, so they don't know exactly what to do when it comes to history. So the point to know is to write a good history, know what condition you are dealing with. To know the condition you are dealing with means you should take the history, go through the motion of examination, have your impressions before you can start writing. Okay, right. So I've chosen preeclampsia because that is central to what we are going to discuss. We are starting. This is for obs and gyne. So we are choosing a condition that will serve purpose for what we are going to deal with. Okay, so preeclampsia I think will be a good example. Just simple. Just preeclampsia, no preeclampsia with severe features. Just this. Okay, so that we can use this one for example, the history taking that we are going to deal with, and this can serve as a prototype for your history taking, right? So as it is done for all history taking, you must have your demographics, okay? So your demographic must be clear, okay? The patient's name, age, residence, marital status, okay? Hometown, religion, and then the other things that you think might be needed in the condition. Then you come to the condition, what the discipline that you are dealing with. Okay, if it is obs and gynae, you want to know the parity. So the parity is to do with the number of births the patient has given or pregnancies. Okay, so you put all together, you put it there, and then the last, if you know the last menstrual period, you put it there. If you don't know the last menstrual period, if it's anything to do with scan 2, you put it there. Okay, maybe dating by scan at this gestation, put gestation at this weeks. Okay, and then we have, so that is going to give you the gestational age. Okay, so the gestational age can be done either from LMP or from the scan. Of course, if you are using the LMP, you should be able to tell the first 13 weeks. Okay, then you have the next 13 weeks, and then the end. Okay, so let's say from the first 13 weeks, every 13 weeks will be the first trimester. Okay, then up to 28 weeks, the next 13 weeks, another trimester in that order. Okay, so of course we always say from 13, so we are saying up to 12, so up to 12, and then 13 to 28, then we have 28, let's say from 28 to what our last either 40 to 41. Okay, that's our third trimester. Right, so say put it there, just on the point. Right, so 13 to less than 28. Okay, then from 28 and beyond is your third trimester. You can also use the rule that every 13 weeks is one. I mean, it's your equivalent of your trimester. Okay, right. So if you are doing that, if you take the first one, so in essence, let me put it this way. Write it well so that you get it. Okay. Right. So in essence, what we are saying is you can have your traditional divisions. Okay, less than 12 weeks. Okay. Then 13 to 28, less than 28, okay? Then 28, so 13 to less than 28, and then 20 beyond 28 to 10 or delivery, okay? That's so first trimester, second trimester, and so on. Some would also say that every 3 months, if you are using your last menstrual period, okay? Every 3 months, okay? It's equivalent to 13 weeks, okay? So you can use that to do your calculation. Every 3 months is equivalent to 13 weeks. Right, so that is also there. You can use that to do your calculation. Right, so, and then of course your scan can come in. Okay, use your scan tool for dating. So this is just a summary of that. So that is demographics, and then the either vitals or either important points that should be added to the history. Now you come to the history itself. So you come to the complaints of the patient, okay, the PC, okay, the patient's complaints, okay. Now the point is, and this point is important. You know, the problem with students, or the problem with taking history in medicine is as a student, you don't really know exactly what people want, or what your lecturers or what your examiner wants. So you are more or less like you should memorize everything. No, that should not be it. Okay. So just assume it should be in the natural world. What I mean is everything there should have a reason for it. Okay. So if you are asked to take history, now you are at the point of the complaint. Okay, the PC, the patient's complaint. So, what are you going to put there? Before you do that, you should first know a thorough pathway for the condition that you are dealing with. Already I've said you should know the condition first. To know the condition, you should know the history and the examination to have differential diagnosis. So, once you know your differential diagnosis, most likely you'll be writing for the one on top of the letter, the first one. Okay, so you should know thoroughly the history, how the progression of that disease is. So if it is preeclampsia, for instance, that I've chosen as my example, theoretically, I should be able to tell the pathway for preeclampsia up to the end of delivery and beyond delivery. Okay, I should know it in and out. Once I know that, I will be able to write a very good history, and that is what I mean. So if I take preeclampsia, let's say from my initial history taking and examination, I think the condition is preeclampsia, or the one on top of my three differentials is preeclampsia. Okay, so the history is going to follow preeclampsia. Once I think that is the condition, the history should follow. There's no other symptom or a sign or whatever that will change with respect to the defined preeclampsia. So it means the history will be the same. If we are taking history for preeclampsia, it should be the same for all of us. The only thing that will change is the scenario, the environment, and all that. But the conditions or the things, the symptoms that we're mentioning to fit this condition will be the same throughout. Right, so this is what I mean. If it is preeclampsia, from our topic on preeclampsia, we know preeclampsia is going to start, or we're going to detect it maybe mid trimester, okay, the mid of the pregnancy, okay, or the mid trimester. So that's about 20 weeks. Because at 20 weeks we would expect naturally for pregnancy to the BP to go down a little, maybe by 10 units, okay, right, to go down a little. So if it didn't go down but rather went up, then we are thinking of hypertensive disease in pregnancy. Let's assume that hypertensive disease that we are thinking of, it's preeclampsia. So I can assume that this is just what do you call it, a hypothetical condition or scenario that I'm giving. So in this case, let's say the person gets to 22 weeks and then the BP shoots up by this. The systolic is more than 30. The diastolic, one of them, is more than the difference on the initial, the base, is more than 15. Or if the person is chronic hypertension, and then I see there's a change of 30, 15. Or if it's not chronic hypertension, maybe the BP is 140, more than 140, 90. Okay, so I have 3 points here. 1, 2, and then 3. Okay, so these are the conditions that is satisfying my preeclampsia. So any of these will maybe change in any of the other organs, end organs. Okay, MAD1, of course, MAD1 can just be proteinuria, or maybe MAD change in the other end organs. Okay, then I'm thinking it is preeclampsia. So I can assume that the patient was probably well. So the first of all, the history, the person is going to tell me maybe I went to the facility and then around 22 weeks and my BP was detected to be very high, okay, and I was therefore referred to Korle Bu for further management. So you see that in my PC, I'm going to capture this, the first point where the person reported maybe around 22 weeks. And then the person's BP was recorded as that, okay? The person went to, let's say, La General Hospital, okay? Went to La General Hospital, and then at La General Hospital, they noticed that the BP was high, and the patient was referred to you at Korle Bu, okay? So you being at Korle Bu, you are now receiving the patient. What is going to be your PC? What is going to be your presenting complaint? So the presenting complaint is exactly in the words of the patient, or you quote it in the words of the patient. So when the patient comes to you, what is the patient going to tell you? The patient will definitely say,